Currently we use the TNM staging system for colorectal cancer prognosis. This system works well to show poor prognosis at stage 4 and good prognosis at stage 1. However, at stage 1 it doesn't tell us which patients are going to recur or not, and then at stage 2 and 3 it's really very poor, with high risk stage 2s often doing worse than low risk stage 3s. So we need a system to use alongside the TNM system to actually help with prognosis and also help to predict what therapeutic strategies patients should have. Classically, the tumour has been staged looking at the morphology of the tumour itself. However, we're now becoming increasingly aware that the tumour microenvironment is very important for how the tumour invades and metastasises. So with the phenotypic subtype, we not only consider the proliferation rate of the tumour cells, but we also look at the inflammatory infiltrate that surrounds the tumour and also the interaction between the tumour and the stroma, which helps with a better stratification system. This system classifies patients into 4 subgroups: the immune subgroup, the canonical subgroup, the latent subgroup, and the stromal subgroup, with the immune subgroup having the best prognosis and the stromal subgroup having the worst prognosis. This is independent of TNM classification, so it can be used alongside this, and it also works across different tumour sites: right-sided, left-sided, colon, rectal cancer, and it works in MMR proficient and MMR deficient tumours, so it seems to be able to aid with prognosis. With this classification system, we have done retrospective analysis. We've looked at it in 1,000 patients from Greater Glasgow and Clyde. We've also looked at it in 2 external patient cohorts, one from Louis Vermeulen's group in Amsterdam and one from Kieran Sheenan's group in Dublin. However, we've not looked at this in a prospective setting yet, so we need to do that to demonstrate that in a prospective setting that it still stratifies patients by survival. We have looked at it in a clinical trial cohort, the SCOT trial, which is a non-inferiority chemotherapy trial that looks to see if 3 months versus 6 months chemo has additional benefit for the patients. In this cohort, in addition to being able to stratify patients by prognosis, it also demonstrates that we can identify a subgroup of patients that would benefit from FOLFOX therapy rather than CAPOX therapy, even although these are both 5-FU based therapy. So in addition to wanting to prove that it has prognostic use prospectively, we'd also like to validate this in an independent chemotherapy trial to show that it can identify a subset of patients that would benefit from FOLFOX rather than CAPOX. In addition to looking at this prospectively and in a validation clinical trial for chemotherapy, we have now been categorising the patients by biological features to see if in the 4 different subtypes we can identify the best therapeutic strategies for these patients, not only using existing chemotherapies and targeted therapies, but also identifying novel targets so that we can explore from a drug discovery angle whether different patient subtypes would respond better to different therapeutic strategies.